Hi, it's Dr. Centeno, and welcome into You've Got the Power. Focus today is going to be on uh, sort of telling a personal story about what I call the Beijing Hamburger and how that relates to the difficulties in performing the PICL procedure safely, and going to talk through that lens about some of the complexities in performing that procedure at a high standard. Uh, so I know that's kind of a mishmash of things. Hopefully you'll see how it all comes together as I give a short presentation. And then after the short presentation, open to answer any questions that you may have either on that topic or on any topic at all. So let's start with the Beijing Hamburger and the PICL. Again, for those of you just arriving, going to give a sort of short anecdotal story about one of my experiences when I was traveling in China and how that relates to the PICL procedure and some of the complexities in doing that procedure safely. So let's go ahead and I'll share my screen here and we'll get started. Looks like that worked. So now we'll go on and give a little bit different today, but you'll still learn some things, I think, here. So when the PICL becomes a Beijing Hamburger, so again, a little off topic here, but I think you'll see all these parts and pieces come together. So about a decade ago, probably more than a decade ago, I was traveling in China in around Beijing, and I was instructing physicians on interventional orthobiologic procedures and how to perform those more complex procedures. And I was teaching mostly orthopedic surgeons in China. And one of their traditions is to have these elaborate lunches and dinners where they love to toast the guest of honor, which happened to be me. So as the focus of these toasts, there's 20, 30 people around a big round table, and everyone is toasting with this white liquor called Baijiu, or Baijiu. And I was expected to drink every one. And obviously doing that, hard to stay sober. So got a little drunk, got pretty sick. And then next day, I'm in my Beijing hotel and I see there's a hamburger on the menu. And I'm like, wow, that's the first US type food I've seen since I've been here. So I'm going to go ahead and order that, a little comfort food. Now, what arrives is what I call not quite a hamburger. You got this patty off to one side, and this isn't a picture of what actually arrived, but similar idea. You got the patty off one side. I still, to this day, have no idea what they made the patty out of because it didn't taste anything like a US hamburger. And then everything else was scattered around the plate. So it was almost as if someone had read the ingredients for a hamburger and put it all on a plate and called it good, meaning that it was just to be able to claim that they offered a US hamburger, which probably made sense for this hotel because they had a lot of US people coming through. So now every time I see something that is, as the English say, a few sandwiches short of a picnic, meaning not quite real, I call that a Beijing hamburger because of that experience I had in that Beijing hotel. So this week, a patient, PICL patient sent me this. Apparently they saw this posted somewhere online. And this was some Indian doctors trying to do a PICL procedure. Now, I have to say that at first I was, really flattered that someone would try to copy the work I've done on this procedure since 2015 and continue to do to advance the concept of non-surgical CCI treatment. But having said that, I'd like to use it as well as a way to view the complexity of the PICL procedure through this lens of looking at the pictures of that procedure. And my hope is that you'll learn something in the process. So issue 1 here, let me get my pen out so I can diagram this for you. So the first thing is that, so let me show you, this is C1, C2 is coming up this way here. So at C1, 2, we see contrast in the facet joints. And while that can sometimes happen, it's not necessarily the best of outcomes, because it means that they got too lateral and into the facet joint. And once that stuff gets into the facet joint, it's difficult to get into the surrounding ligaments. So again, the reason for pointing this out is more a discussion of how complex this thing can be, meaning specifically where you put that needle makes a big difference. And we've only learned that through, or I've only learned that through doing hundreds and hundreds of these procedures day after day. Issue 2, there wasn't actually an injection of the alar ligaments, even though one was claimed. This is where they got the injectate. And, you know, this one here is probably a little bit of the transverse ligament. The actual alar ligaments come up this way, like that. So at no time did these guys ever demonstrate that they actually got into the alar ligaments at all. This one's probably a little bit of the accessory ligament. So again, interesting, because, you know, you would think that obviously they claim to get into alar, but they never did. Now, that's obviously understandable. They don't know this anatomy. They don't know really what it is they're injecting. It's probably the first couple times they've ever done this, but they're not getting into those alar ligaments. Issue 3, no endoscopy was used to visualize the back of the throat and keep it sterile. And that's a big problem, because we use an endoscope that goes in here that then shows us exactly what the back of the throat looks like, because it's not uncommon that the patient might bring up a small amount of fluid during the procedure and totally desterilize the sterile field, or that the patient might not be as dry as they should be, and it's hard to keep the sterile field sterile, or that the tongue moves and all of a sudden your needle grazes the non-sterile tongue as it's going into the sterile field. And that's just not something you can control without having an endoscope, being able to see a nice big picture of exactly where it is you're injecting. Here it seems like they're kind of looking down there and throwing the needle in. Issue 4, you can see that they're using an ENT mouthpiece here, and that'll work. The problem is you can't x-ray through it. So there are going to be times where the structure of what it is you're using to keep the mouth open interferes with your ability to see the injection targets. And that's why we created a 3D printed custom mouthpiece, and we've got several, to both control the tongue and allow the imaging to pass through the appliance, meaning the device itself. Issue 5, and this is a big one. I get asked this all the time. Why don't you just do PRP in this space? And there's a lot of reasons for that, having to do with PRP is not as powerful in getting ligaments to heal as bone marrow concentrate. But there's another big issue, and that's this right here. Meaning that when you take IV blood for PRP, the problem is that that's in your chain of possible sterility contamination events. That's the least sterile way we could take a sample from somebody. And so the problem is that if we have PRP and we're taking that from the vein, that's less sterile. And so there's always a possibility that we get a contaminated PRP sample. Now, listen, contaminated PRP sample in other parts of the body not going to be as big a deal as this space, where if you get an infection, you could be talking about meningitis. So we do a full surgical prep, and we get any bone marrow through this hypersterile scenario where it's a full surgical prep to take that bone marrow. So that's much, much more sterile than taking whole blood from an arm and making PRP. Issue 6, there's only one C-arm. We've now since learned that using a single C-arm, this is actually a very small C-arm, but even using the larger spine C-arms and only one axis reduces your ability to get into some of the more complex places that you can get into here. So it just reduces the accuracy of the procedure itself. And then issue 7 is we've got this really big 22 gauge needles. Now we've tried to use these because they're super easy to drive. The problem is that the hole created is big enough where the stuff you inject just leaks out the front area of the spine. So that doesn't happen with 25 gauge needles, but those are a bit more complex to use, and less experienced spine providers have a hard time using smaller 25 gauge needles. They tend to be more comfortable with this 22 gauge approach. But forgetting about all of those important things, the single biggest issue is that if we have a severe infection or other complication due to what I call this Beijing Hamburger effect, that could end the PICL procedure for all patients moving forward, meaning that if those guys were to have a serious complication or somebody else, and then they publish on that, our ability to do the procedure would be substantially hampered. And listen, this is probably the most complex procedure I've ever created and done. I've created dozens of procedures from scratch, orthobiologics procedures, where we did the first procedures on Earth. But none of them are in this category of difficulty, where you're managing the airway, you're using special 3D printed devices to be able to see what you need to see. You're using endoscopy, 2-axis C-arm, et cetera, in order to be able to perfect this. So while I'm certainly flattered that these guys have tried to copy what I'm doing, it has a consequence if something goes horribly or terribly wrong. So in summary, this discussion doesn't really scratch the surface of how difficult the PICL procedure is to safely perform. But again, you know, I need to continue to work to get this procedure into the mainstream so that it's got enough momentum behind it, so that if something were to happen through one of these copycat things, that the procedure isn't wiped out and relegated to the medical dustbin of history, because that's the biggest concern. In my medical career, and like I was saying, I'm getting older, I've seen a lot of procedures get relegated to the dustbin of medical history that were pretty good in the hands of the creators, but they got into other hands, wasn't done just right, bad things happened, the procedures just went away and aren't done anymore. So that's the big concern here, is how do we move this forward in the right way so that once I go off into the sunset and retire 5 or 10 years from now, that there's enough high quality providers out there to get this procedure so that the procedure has a life of its own, and lots of patients can't afford themselves of getting this procedure without any potential safety issues, who can avoid upper cervical fusion surgery. So let's go, and I will see if we have any questions. Let's get rid of this and go to questions. Okay, bunch. Duck P, when you inject PRP into the 0-1 joint, how likely is it that some of that PRP will end up bathing synovial lining of the posterior facet capsule? Posterior lining of the, so the synovial lining is the inside of the joint. It encompasses the entire joint, anterior, lateral, and posterior. So that's going to get definitely into the anterior, posterior, all of the synovial capsule. Duck P, why is it some people with alar laxity don't get bobblehead? Example, 2 patients with the same exact problem with alar laxity causing 3 millimeters of overhang, but only one of them can't hold head up. Oh, that's probably a combination of lots of different things. So that could be due to problems lower down the spine, meaning is there a big kyphosis pushing the head forward? That's going to put more weight on the head. Does one patient have more muscle loss than the other in the upper cervical stabilizing muscles? Are there other problems like irritated joints that make it hard to hold the head up? I mean, there's too many variables there to count. Duck P, and a young patient in their 20s, when do they typically start noticing more tightening stability in their ligaments after a PRP? Should be fairly quick, within 3 to 4 weeks, somewhere in that time frame, max 6 weeks. It's been advanced by Stacy Kaufman. PICL patient rolled over onto her arm while asleep and popped side of rib and landed on my arm. I think third rib from bottom, so mostly hurts behind my boob. My DO moved it back and of course still sore, but of concern was a small popping, cracking sound, mostly in the front, but sometimes the back when breathing. Happened last year, but still no crack. Is this normal? Stacy, best thing to do would be, if you've already tried osteopathic manipulative medicine to get it back in place, then just point it out, and we can also treat some of those ligaments if some of those got damaged, and that would be the fascial ligaments around the ribs there. Ulysses, can muscle atrophy affect the whole body, like mid-back, low back, hips, and SI joint if left untreated? What treatment for it, especially at a young age? We need to know what muscle we're talking about is atrophy. Can muscle atrophy start at the cervical spine first? If you're talking about deep segmental muscles, stabilizing muscles like multifidus, the answer is yes, it could. Regenetics, been advanced by Sherry Scott. How far in advance do we need to schedule a PICL procedure? What's usual time between evaluation of the procedure? That's variable. I would say right now, 4 weeks, 3 weeks, something like that. But we have people all the time who can't make it for whatever reason. And so it's certainly getting quicker if you're on a cancellation list. Era, good day, Centeno. When injecting PRP in the cervical spine, is it true that in the first week it'll be tighter than normal, followed by a period which is weaker and more vulnerable than it was, then eventually improving? More like if it's swollen during that first week to 10 days, sometimes 2 weeks, depending on the patient. Everything feels more tighter and stable. Once the acute swelling goes away, kind of goes back to what it normally is. And then as the ligament tightens, which is going to be more depending on your age, less if you're young, but let's say a 40, 50-year-old, as it tightens more in that 4 week to 2 to 3 month range, then it starts to feel better. Finn, how close can you start curve correction to rounds of injections? Is there a specific type, level of instability prohibits dental roll, etc.? Yeah, I always tell patients that that's a very individual decision on when to start curve correction. So I think the best way to test that is to roll up a small towel, put it behind your neck in the middle, lie face up on that, and see if that feels good without causing a flare-up. If that feels good without causing a flare-up, then I think it's reasonable to start graduating towards a dental roll, or seeing more likely a chiropractic biophysics or CBP provider at idealspine.com to start that. Now, you certainly want to get that approved with your doctor. So make sure your doctor gives you the thumbs up that you in particular are ready to start curve correction. Rosalind, if the posterior of my skull lifted up and is out of its cradle by 6 millimeters, how many millimeters would you expect when I reduce that distance by? Not quite sure what you're referring to there. Are you referring to during invasive traction, the skull moved 6 millimeters? If that's the case, a lot would depend on what was being injected. That would be a hard thing to fix with posterior PRP, because the main ligaments that prevent that would be, for the most part, internal. You could get a little bit by doing the nuchal ligament, but realize that you've got the apical dens ligament that would prevent that, the AAOM, the PAOM, in addition to the alar ligaments that would all reduce that. So that's hopefully that answer helps. Rosalind, can you increase the CX every 25 degrees just by tightening the posterior ligaments? Usually the CXA isn't the problem. It's the collapse of the CXA, usually with flexion of the head, meaning most people with low CXAs don't have issues when their head is like this. Those issues develop when they bring their head down. So based on some of the work of Henderson et al., the number to be concerned about is close to 120. So if you are bringing your head down like that, and the CXA, let's say, starts at 130 and then goes to 122, it's not increasing the CXA at 130. That's not going to do much of anything. You want to reduce the decrease in the CXA with flexion so that there's not as much stretch on the upper cervical cord and medulla. So I know from a surgical standpoint, they're trying to change those numbers, but they're doing that because they're using an inelegant solution, right? They're fusing stuff, meaning they're taking things that were built to move and making them not move. So in that case, the best you can do is to maybe try to increase the CXA a little bit and then lock it there. Our goal is quite different. Our goal would be to have the CXA not collapse towards 120 when that person is flexing. And that can be done in part with posterior ligament injections. Many of those same patients have issues with a transverse ligament, which is internal, allowing the dens to come backwards with flexion, which further causes problems because it brings that dens into the upper cervical spinal cord and medulla. So posterior injections are reasonable to try first. If that doesn't get you where you want to go, you probably need to get that transverse ligament as well. And again, in summary, the goal is to change what happens with motion. These numbers generally all by themselves in static measurements don't mean a lot. It's what happens to them when you move. Fact, I read that vagus nerve can contribute to tinnitus too, can also be related to POTS and dystonia. Well, certainly POTS, yes. As far as vagus nerve causing tinnitus, that's, I suppose, theoretically possible. Dystonia, less so. Finn, do adjacent injections benefit nearby ligaments? For example, dextrose injections can be made the whole back of the neck swollen and inflamed, so there's a beneficial paracrine effect. No, doesn't work that way. Yeah, I'm not even quite sure how that would work. Paracrine, just so that you know, refers to a cell that releases chemicals to get other cells in the local vicinity, we're talking about nanometers away, to do certain things. So for instance, the cell right over here that's 10 nanometers or maybe as much as a millimeter away from another cell might release a chemical that says, hey, come over here and help me make extracellular matrix. But a paracrine effect doesn't work across centimeters or inches or feet. So that's not going to work at all. All of those structures are separated by boundaries. So no, there is no impact of injecting these posterior ligaments to try to make other ligaments tight. It's a nice theory, but I think it's more sales and marketing than it is medical or scientific reality. Fascian, which structure would typically cause a pounding headache, not pulsing like a migraine, like the heart is beating inside the head too? It could be lots of different things. Fascian could be the upper cervical bursas that we've talked about, could be the facet joints, could be the occipital nerves, could be compression of the internal jugular vein, lots and lots of different things there. Spin advanced by DB, how long between PICL procedures is needed? We generally advise approximately 3 months between procedures at a minimum, and then sort of 3 to 4 months depending on your age. Ulysses, can bone spurs cause headaches on the upper facet joints, especially moving around a lot? Not really cause headaches. Bone spurs are more evidence of instability. It's your body's attempt at trying to add bone to stabilize something. So they're not really 90% of the time a cause of pain as much as they are evidence that something is moving around too much. Fascian. Gotcha. Rosalind, if the disc between 5-6 is completely gone and the area is bone on bone, now, can your PRP procedure prevent the need for surgery? And if so, how? I don't know clinically what we're talking about here. So a lot of that depends on if C5-6 is symptomatic. If so, how is it symptomatic? Is it symptomatic because there's compression of a nerve? Is it symptomatic because there's a disc bulge there? Is it symptomatic because it's unstable there? Lots and lots of different questions that would have to be answered to accurately figure that one out. Finn, a low CXA is indicative of AAI, but won't it be influenced by tilt of the head during imaging? If so, could a patient improve their CXA by adopting more upright chin-up posture? Yeah, Finn, that's a great point. I love the question. And I love the question because this just happened this week. We had a patient who was seen at a European upright MRI imaging center and was given the diagnosis of CCI due to a low CXA and neutral. CXA was approximately 125 or so pretty close to 120. Now, what was interesting is that when the patient went into flexion, the CXA increased to 140. Should go the other direction. And if you looked at the patient's posture and then the patient's spine on the image, the patient had severe kyphosis, was a young girl, but again, cell phone syndrome, doing this all day, and their head was way forward. And in order to be able to see, she has to crank her head back this way. So that's what made the CXA very low. So the CXA was postural. It was being caused by the really awful posture and not some harbinger of instability. Now, she may have instability. We're going to get some additional imaging to try to figure that out. But it goes exactly to the point that you bring up, that you have to be very careful when looking at these numbers because they don't exist in isolation. If you've got awful kyphosis, which is a dowager's hump, and in her case, a dowager's hump at like 16, and your upper thoracic spine is going like that forward, then that's going to decrease your CXA independent of anything else. So the CXA in that case was a misdiagnosis for instability. She may have instability due to other measurements, but that CXA was because of that posture. So thank you very much for bringing that up. In fact, I'd love to do that Facebook Live in order to try to illustrate that point. Lissy, do you believe steroid injections or RFA could worsen muscle atrophy in the long run? Certainly RFA will increase the muscle atrophy or muscle dysfunction. I just had a patient today that regrettably, she's on this RFA train. She's gotten 6 in a row. I had to tell her that whatever her chances of PICL helping were, it's my belief that because she's on this RFA train, that weakens those muscles, and those chances of success went down, meaning that it takes ligament stability and muscle stability to get back to normal. And if the muscle nerves going to the muscles have been nuked 6 separate times and burned 6 separate times, meaning cooked, that's what RFA does, then the likelihood of getting normal muscle function back, even if we got normal ligament function back, was low, and that was going to impact potential recovery. It's been advanced by Liam. Does your pain level have anything to do with PICL success? Does the length of time from the accident have more to do with it? Good question. I can only tell you my personal belief is that if we've got a patient with extremely high pain levels, that's going to be a difficult patient to treat. Normally that indicates central sensitization, which I've talked a lot about on here, can have an impact. And then the biggest concern with time since accident or injury has to do with whether or not, and we've talked about this a lot of times, the neurologic changes have gotten baked in or not. And it's 50-50 on that one. Jingesh, do you recommend PICL if unilateral C1, C2 overhang of 3.5? Can alar and or accessory ligaments heal on their own in this situation, not treated? If they can heal, then how long does it take to heal and resolve related symptoms? Yeah, so 3.5 is right in the cutoff. Cutoff is 3 to 4. And can they heal on their own? Sure, I would give them a good 6 to 12 weeks to heal on their own, no different than any other ligament injury in the body. Obviously, if it's not healed at that point, then you get into that subacute phase where maybe it heals, maybe it doesn't. And then you get into that 3 to 6 month range and it's not healed at all, or let's say it's 6 months, there's no change, then I think it's very unlikely there's going to be any natural healing. Evan, is it possible for posterior injections to lead to more instability? Generally don't see that. They're either going to work or they're not going to work. So I think that one's much less likely. Mircea, thank you for the presentation. Dr. C, today marks the 4th month for me, and already 3 months I felt 30% improvement in symptoms. Can't wait to get a second appointment. Thanks for the update, for sure. Finn, does CCI, AAI ever cause jaw retraction towards the cervical spine? If so, is this adaptive muscle grinding, maladductive muscle should be released? Well, obviously not released surgically, but if you mean myofascia released, I think that's a reasonable thing to do. Just realize that, as I talk about a lot here, the anterior mechanism for neck stabilization involves these TMJ muscles, the strap muscles up front here, the longus colli, the longus capitis, the deep stabilizer muscles. So those commonly get overloaded in patients who have these kinds of problems, meaning upper cervical instability. So you can see changes in the jaw because these muscles up front are trying to stabilize the head on the neck. Stacy, my neck is a hot mess. I'm wondering whether I should be exercising the muscles before next PICL, or if I could cause tears to worsen. I think if you can tolerate exercise, even small amounts of exercise, that's probably a net positive. Duck P, can I still strengthen the suboccipital muscles without using the laser pointer? I don't feel my suboccipital is working when I use the pointer. Sure, yeah, you can certainly do that, yes. Era, You recently talked about the skull sliding forward CCI type and said an upright MRI in that situation tells you more than a DMX. Does this mean you don't need a DMX in this situation? Yeah, I think an upright MRI will give more information there. So if that's the type of instability you have and nothing else, then an upright MRI would be the thing to do. Stacy, oh yeah, I got quite drunk. These guys kept toasting, and these things looked little, and the next thing you know, you'd have 20 of these things, and you felt embarrassed to say no because they were, the translator was translating the toast, and they were all really nice toasts, etc. But it's really easy to get drunk at these things. I don't know how they do it because I hadn't had that much to drink since college. Mercia, question regarding MCAS and CCI. What are so many CCI patients have MCAS? It's possible it's already there, but got more apparent at CCI onset. Does MCAS improve as CCI improves or not necessarily? Yeah, I think MCAS is related more to the genetic factors around EDS. So that's one connection there. Now, another possible connection could be that irritation of the vagus nerve changes the release of anti-inflammatory cells from the spleen. And we talked about that in another video, how the vagus nerve is not only involved in things like heart rate, but it's also involved in promoting that anti-inflammatory healing response. So it's theoretically possible that there's a connection there between that and MCAS. Duck P, can C0C1 facet inflammation cause the local muscles around that joint to turn off? Absolutely, yes. Do you know any supplements that can heal ligaments faster, especially in the neck? I do not. Amity, does C6-7 epidural injection with PRP help in anterior, posterior, or upper cervical instability? What ligaments does PRP come in contact with when injected via cervical epidural? Shouldn't have any impact at all on upper cervical instability. Now, what might happen is that the muscles locally at 6, 7, 5, 6, C7T1 might be turned off, and that can cause the bigger muscles that go all the way up to the head to overwork. So that might help a little bit. That's why if we see a problem at 6, 7, we'll treat it epidural or through a facet overfill when we're treating CCI. But one shouldn't have directly to do with the other at all with regard to CCI and a 6-7 epidural. How far up can PRP travel in a cervical region of injected? No, you don't want it to go to 6-7. In fact, that would be malpractice if it went up that high because that means you'd got an intradural. Epidural, you're probably not going to be able to push it up higher than around 4 or 5, somewhere in that range. And you don't want it to go all the way up because if you're using anesthetic there and it goes all the way up, the patient can't breathe. That's why it's malpractice. So you would have to get the crash cart out to keep the patient alive until the anesthetic wore off. So you don't want to go up that high. Vivan, if dural strain and coccyx, removal possible during cord strain with complex commit. Don't know what the question is for sure. If dural strain and coccyx, removal. I think what you're maybe saying is that if you remove the filum terminale as it inserts into the coccyx, can that change the overall posture of the spine? The answer is yes. It also is a permanent change to the neurologic system. One of the reasons why I've talked so much about not doing cord detethering until there's no other way to get to do that, because that's such an invasive procedure. It permanently changes the biomechanics of the central nervous system. And once we cut that, the bottom of the cord called the filum terminale, there's no way to go back. So I think that's what you're asking, but let me know if I got that or not. Jingesh, can bilateral 5-1 facet injection help with lumbar radiculopathy of ESI better than facet injection with lumbar radicular pain, or facet injection be effective with the same problem? The 5-1 facets, and really all lumbar facets, can leak into the epidural space. So if you inject the 5-1 facets, you will get some of whatever it is you inject epidural. There won't be as much as if you injected directly epidural. So if we have someone with very low level radiculopathy, and they've got more facet problems, usually you can take care of both by just injecting the facet. Now, if they've got more lumbar radiculopathy and a facet problem, then you probably need to inject both areas. Jingyesh, can trigger point injections help in the base of the skull pain due to muscle spasms caused by instability? They can certainly help the muscles be more efficient. Usually muscle spasms are caused by instability or malposition. So it's unlikely to help that, but it might make the muscles more functional. ZA, if first PRP treatment provides significant improvement, how long to wait until doing a second PRP treatment? Can getting another treatment too soon disrupt healing at all? Yeah, I think it's important to realize that we should have some distance between these treatments. I know a lot of prolotherapy clinics love to do this prolotherapy once a week, once every other week, once every 3 weeks. I don't know that we have any evidence that that's any better than doing, for instance, prolotherapy in the ligaments every 4 to 6 weeks and letting most of that inflammatory healing cycle die down before you hit it again. Same thing here with a second PRP treatment. If our focus is on ligaments, we should probably wait some. Now, let's say we're treating a nerve or a joint, then I think you could do it weekly. It's probably overkill in the vast majority of patients, but you could do it. It's probably not going to hurt anything. WW Soft, is an upper cervical MRI with flexion extension likely something clinically significant that doesn't appear on DMX? How would it be? Find something different 1% of the time. About 1%, but as far as they just look at different things. So for instance, on a DMX, I can't see what's happening with the dens in the spinal cord because those things are not visible on the DMX. I can't see what's happening with the relationship between the skull and C2 in any measurable way. I can't measure the CXA on a DMX. Hard to measure the grab oaks on a DMX. So we're just looking at different things that might talk about different kinds of instability. The DMX, it's great for looking for type 2B instability. That's that atlantoaxial side to side and rotational instability at C1, C2. It can also see types of instabilities where you've got the ADI opening up in flexion between the atlas and the dens. It's not going to be good, for example, in looking at like a type 2A instability with a collapse of the CXA. Amity, are cervical facet injections more helpful in treating cervical instability as compared to cervical epidural injections? Neither. So the answer is neither. Neither one of those is going to treat cervical instability at all. Remember, cervical instability is a function of ligaments. Now, to the extent that those help to turn on muscles, they might help someone feel more stable. But instability, as we're talking about it, is due to a subfailure ligament injury. So without treating the ligaments, you're not going to treat the instability. So neither one of those treats ligaments. Isabella, is it normal to still feel exhausted 4 weeks after posterior 0 through 7 injections? I need to know more, Isabella. What kind of injections do you have? PRP injections, bone marrow injections, who did the injection, etc. Finn, you recommend lowering the background systemic inflammation part of PRP using fish oil and curcumin. What windows should these be paused for surrounding injections? Yeah, so I would stop the fish oil a good week or so before your procedure. The curcumin can stay on longer. You'll probably only need to stop it for about 3 days before the procedure. Then right after the procedure, you can go back on both. WW Soft, can cervical flexion extension studies be performed in the supine position? and produce results that are useful as equivalent standing MRI. They can. It's not going to be as useful as a standing MRI because it's not with gravity. Isabel, is it important to feel better before treating another area like the lower back? Usually. You see people saying BPC 157 can heal ligaments, tendon, muscle. Yeah, that's all bullshit. I hate to put it that way, but we don't have any evidence that any of that is actually true. I've looked at that in detail. There's one animal, or actually not, in vitro lab study looking at tenocytes that showed that direct application of BP 157 on the tenocytes caused some stimulated healing similar to PRP, but not actually as robust as PRP. And that doesn't say anything about what happens in a real human being when you inject it or ingest it. I mean, I love all the Facebook marketing, et cetera, but it's just, there's no proof that that's actually a real effect at this point. I would certainly encourage those companies to do real clinical trials, but I haven't seen anything out of a single one of them yet. And I know they're making tons of money because I see a lot of patients buying it. Edward, if someone does not have EDS, is there any way looking down at textbooks for 9+ hours a day for school could damage transverse ligament? Probably not. Strongest ligament in the body. Jennifer, I had an RFA one time on the right side. How much damage do you think has been done? It would never do it again. Well, one time irreversible damage. Yeah, no one knows the answer to that, Jennifer. You know, we are still figuring out as physicians the long-term effects of RFA. For example, there's a big debate in the physician community right now whether or not RFA causes visible muscle atrophy on MRI. There's studies that show it definitely does. There's studies that seem to suggest by advocates for RFA that it doesn't. I would say it's immaterial. We know it destroys the ability of the nerve to make the muscle work. Can that function come completely back? That study's really never been done. So that's a hard one to answer. I would like to think that at some point the muscle comes back and gets reinnervated and is normal, but I can't give you any information that supports that. I know enough Italian to know I shouldn't click on that one. Is NUCA better than CBP? Completely different approaches. So NUCA would be an upper cervical chiropractic, low force adjustment technique. Chiropractic biophysics is increasing the curve. So two totally different things. WW Soft has a patient with CCI reported that taking a certain supplement made it easier to move their extremities. Methylated B complex does it for me for whatever reason. Yeah, there's some evidence that B vitamins deficiencies could lead to nerve problems. So perhaps there's a B vitamin deficiency there. That would be an interesting one to see. Rosalind, with regards to earlier, my skull is permanently detached from its cradle at the rear. In neutral, it's out of its. So Rosalind, I'm not quite sure what you mean by its cradle. I'm assuming you're talking about the skull versus the atlas. It's not in traction. Does this mean NUCA could just whack it back in? Yeah, Rosalind, you're not using medical terms to describe what's happening. So I'd have to look at your films to get a better idea of what's occurring to see what it is we're talking about there, because none of that jives with the medical terminology describing what could be going on. Ulysses, can epidural work with PRP or stem cells? I think what you're asking is, can you do an epidural with PRP or platelet-based stuff? Yes. It can also be done with stem cells, depending on what kind of stem cells you're talking about. Isabel, how does thoracic instability influence upper cervical instability? How important is it to stabilize that as well? Can treating the T-spine also help with shoulder issues? Yeah, so our goal would be to try to treat it all at once. Now, some patients can't tolerate that. And so in some of those patients, we'll start treating the upper cervical spine. Some of those patients treating lower issues, but they both need to get treated. And yes, treating thoracic spine can help with shoulder issues. Gotcha. Why does every doctor mix PRP and stem cells together to make better treatment? I've seen this in a video, especially in the neck. They got that from us. Realize that anyone's using stem cells right now learned from somebody who learned from somebody who learned from somebody who learned from somebody who learned from us. Meaning we did the first stem cell treatments in the musculoskeletal system for 99% of the treatments we talk about here way back in 2005. So that's because we noted in culture that PRP stimulated stem cell growth. So that comes from our clinic way back in 2005. Isabella, is it normal to still feel exhausted 4 weeks after? Yeah, PRP at algo cells. Not normal. So if that's new, I would contact the doctors there. Stacy, we want to see if you've said a topic should be going to CS website or Regenix website. Most of my stuff is on the Regenix website. Some of that stuff sort of got rewritten by Dr. Schultz for the Centeno-Schultz website, but most of my original content is on the Regenix website. Now that's different from things like the book. The book is on the Centeno-Schultz website. Obviously, I've got my own YouTube channel, and my own YouTube channel has all of my content as well. Vivan, coccyx strain from congenital tailbone removal and congenital neck convex. Yeah, so I think what you're asking is, can removing the coccyx, yeah, I think, listen, Vivan, you're probably gonna have to send me a direct email on that one, because what you're, I think, saying is that someone took out the sacrum, or maybe you were born without a sacrum. I'd need to know more. Yeah, Ivan, I wish you the best. Absolutely. Again, the concern was that wasn't a PICL procedure. That was certainly an attempt at trying to do a PICL procedure. So I certainly wish you the best. Stacy, how recent must an upright MRI and DMX be before PICL? Is it 1 year too long if symptoms still the same? No, I think that's okay. 1 year. What are your thoughts on IV stem cells? Can benefit ligaments specifically? Not going to happen. No. So 97% of the cells will get trapped in the lungs. That's called a pulmonary first pass effect. So absolutely not going to help your ligaments. That would be a scam. Finn, I've heard of protection injecting the deep cervical muscles alongside Prolo injections reactive to the muscles made big improvements in the curve. Do you guys do that too? We do. I don't know that it reactivates muscles and restores the curve. I think that's a little bit cray-cray, but it's certainly a good practice. And then I think this is my last one, because I do have to end about 5 minutes early today. I've got a podcast to do with a podcaster in Germany on some of this upper cervical stuff. Arno, how safe is the transverse process shaving to make space for the internal jugular vein? Again, if we're talking about something that is done when all else has failed, then it could be reasonable, but it's going to destroy certain stabilizing structures because there's a lot that connects the transverse process. You've got the AO ligament, anterior and posterior. You've got most of the upper cervical muscles that attach there. So that if you detach any of that, you're going to cause severe upper cervical instability. Okay, guys, thank you so much for watching. I've got to get to another meeting. We'll have to see what happens next week. Next week, I'm going to be down at our Grand Cayman Clinic seeing patients there. I will have to see what I'm able to do as far as Facebook Live. We might just sort of have a random one during the week or something like that, because I'm not 100% sure of my schedule. So I'll try to keep you informed on that. If we do that, I'll advertise it during the morning, and then I'm back in town the week after that. So you guys have a great weekend. Thank you so much for the great questions, and I will probably see us sometime randomly next week when I figure out what my schedule is once I get down there. Thank you so much, and have a great weekend.